computer vision people, I mean, from all different departments of UCLA. And we started to work on this like 13 years ago, and we developed a robotic platform dedicated for eye surgery. So some disclosures. I have some patents via UCLA, and I've been granted a few NIH grants, as well as some lecture fees. So robotic surgery really started in 2000 when the Da Vinci surgical system became FDA approved for laparoscopic surgery. And since then, the number of Da Vinci installed worldwide has been increasing. Now we have more than 4,000 platforms installed worldwide. And the number of surgery performed with that system has been as well very quickly increasing. It was just a few thousand initially in 2001 and 2002. And a couple of years ago, more than 600,000 surgery, laparoscopic surgery, were done with this system across the world. Since then, the number of different robotic technology or robotic platform which have been developed for other surgical procedures have been increasing. And you can see on this image, actually, I'm not sure here. Okay, on this there are many different robotic platforms dedicated for different type of surgery, and the number of conditions you can treat now with robotic technology is increasing very quickly. You can see the list on the left-hand side. Interestingly as well, the number for each procedure, let's talk about the prostatectomy. In 2000, 100% of them were done with a traditional technology, traditional way of doing surgery. And over the years, it has been a shift between traditional surgery and robotic surgery. And now in the US, almost 100% of the prostatectomies are performed with robotic technology. So why that? I mean, robotic technology can really provide some superhuman capabilities. For laparoscopic surgery, it provides an elegant access to critical surgical targets. It's improving the precision. It's improving the visualization. It can filter out the tremor. It can increase the maneuverability and amplify the scale of motion, and allow also some automation for some specific tasks. So when you look at this video, what you can see here is that compared to a surgeon which would, do a nice line but not as precise as the robot, when you can see here on the right side, when it's done with robotic technology, it's much more precise. The cut for even a basic task can be accomplished more precisely with a robot. When you look here between robotic surgery for suturing, you see this is the path of the needle. When it's done manually, the cleanness of the path and is not as good. I mean, robotic surgery can really provide much more precision. What about eye surgery? We already have a unique type of surgery with very nice three-dimensional, high magnification view of the intraocular structure. We have minimally invasive instrumentation. We have a high maneuverability. However, we still have some limited performances. For instance, in terms of vision, the visual feedback is limited. When you do cataract surgery, we cannot see behind the iris. When we do retina peeling or retina dissection, for instance, in complex TRDs, we don't see everything. When there's some blood, it's very difficult to know where the retina is or under the membrane where it is. So we still have some limited visual feedback. In terms of tactile feedback, there is no tactile feedback. Our capabilities in terms of sensing is lower the threshold of what we do. When you do, let's say, laparoscopic surgery, you can feel something. During eye surgery, we have no tactile feedback. Robotic surgery can improve that. Same thing, we have a physiologic tremor of 100 micron, and robotic surgery can help us limit this, filter out the tremor. So we really think that robotic technology can provide some superhuman capabilities, augment manipulation by, as I said, filtering the tremor, scaling the motion, and providing some collaborative capabilities, and augmenting the sensing. As I said, we have limited visual feedback and no tactile feedback. This technology can really help us provide much better visualization and provide us with tactile feedback. And we think that this can lead to better surgical outcomes or new surgical manipulation, something we can even not envision now may be possible with robotic technology. So robotic system can provide different levels of collaboration, from the traditional surgery where the surgeon is controlling the tools and the vitrectomy system of the phaco. This is traditional surgery. Robotic surgery can provide semi-autonomous system, a level of collaboration where the tool will be controlled simultaneously by the surgeon and the robotic platform, to fully automated system where the robot will be in control of the tool, controlling everything, the instrumentation, the phaco machine, the vitrectomy machine, and the surgeon will be there only to supervise the surgery and override if needed. Let's say a LASIK surgery for now, the laser is delivered by the system. It's kind of a robot where the surgeon is controlling, supervising, interacting if needed, but it's kind of a robotic surgery already. Different level of design, different type of design, from the handheld or smart tool to co-manipulation and telemanipulation. So as I said, the handheld, which is the first design, all the technologies included or incorporated in the handheld. This is called the micron, and actually the tip will, or the system itself will filter out the tremor. So if the surgeon has any, you can see here, so everything is included in the handheld. So if you have any tremor, the system will filter out the tremor and provide much more precision. So this has been developed by Johns Hopkins. They can incorporate, as you can see here, some OCT probe within the shaft of the instrument to, same thing, help for increased precision. So far, two systems have been tested on human. The first one is from Leuven, the University of Leuven in Belgium, and it's based on co-manipulation. Co-manipulation meaning that the instrument here is controlled simultaneously by the surgeon's hand and by the robotic arm. And so this can provide more precision, but also, let's say, if you have to do a vein cannulation. I'm not proposing vein cannulation. We don't know if it's working, but let's say in the future we realize that RTP injection for 10 or 20 minutes in the vein for vein occlusion may work. It's very difficult for a human hand to maintain the needle during 10 or 15 or 20 minutes within the vein. You can have a system where the robotic arm is holding the instrument, the human is controlling as well with a co-manipulation tool, gets inside the vein, stays stationary for 20 minutes, and then the surgeon can take over again. So this system has been tested on human for vein cannulation in Belgium and worked pretty well and increased precision drastically. The other system tested on human is based on telemanipulation, meaning the instrument is mounted on the robotic arm and controlled by the surgeon's hand, either at the surgical cockpit or just close by manipulating the robotic manipulators. So Mark de Smet here from Netherlands has developed this system. It's from the company called PRECEYES, and they tested the system on vein cannulation, so on human, on vein cannulation and epiretinal membrane. There are currently 3 systems installed in Europe, one in UK and a couple other somewhere else, and they are through trials starting to use this system on Vitreo-Retinal surgery. So what about the UCLA project? We call it the IRIS for Intraocular Robotic Interventional and Surgical System. We started in 2007, as I said before. When I went to the CASIT, I discovered this center of research and started to work with the people there. And we started to design this platform, I would say, 8-9 years ago. So we have 2 goals. One is fully automated cataract surgery, and the other one is teleoperated Vitreo-Retinal surgery via immersed augmented sensing. So, you know, here I know that we don't have the same needs. In India, I mean, you do an incredible job in doing so many cataracts for the people from here, Tamil Nadu. I mean, in the US, you know that the system is very different, and we are not envisioning using the cataract robotic platform right away, but we think that over time, if the technology really shows some benefit, and I'm convinced that it will be better than human surgery, then over time this system will take over, and hopefully a shift will be done between traditional surgery and robotic surgery. So traditional surgery, the surgeon is controlling the instrument inside the eye, and either the phaco or the vitrectomy machine. You have the patient, and the only feedback would be limited visual feedback through the surgical microscope. So what other system, robotic system provide is increased precision and tremor filtering, but still the surgeon is controlling the robot and the phaco or phaco machine, but the only feedback he will get will be through the microscope, and is still a limited visual feedback. What we are developing at UCLA is OCT guidance. So we have real-time, fully OCT scan of the anatomy of the part of the eye we are dealing with, either the cataract or the retina, and this information is processed in real time and helps provide to the surgeon and enhance visual feedback. You probably know what is augmented reality. We'll talk about this later. So we overlay on the image, on the microscope through the Ingenuity, for instance, or other visual system, much more information from the OCT. But this OCT information can be also processed to provide haptic feedback. So we can provide to the surgeon through the surgical cockpit some haptic feedback. So enhance optical or visual feedback, enhance haptic feedback, but the system can work also as a closed loop where all the information coming from the microscope and the OCT will be enough to guide the instrumentation inside the eye and generate some automated trajectory inside the eye for cataract surgery or specific tasks during Vitreo-Retinal surgery. So in cataract surgery, even if this surgery is really well known now and complication rate is still, I mean, pretty low, there are still papers describing posterior capsule rupture, and there are still some capsular rupture. Even if you are a great surgeon, sometimes you have that, and one reason is that the posterior capsule is transparent, and you need experience and training to really kind of know where the capsule is, but we never know exactly where it is. I mean, we don't know unless we touch it, how far it is from the tip of the instrument. So there are still some posterior capsule rupture. The other thing is posterior capsular opacification. In almost 50% of the case, within 5 years, we get secondary cataract. And this is in particular done because the cleaning of the bag is not complete. You always, we always leave some lens material at the equator or on the posterior capsule, and then this builds up into PCO. And we think that if we can do a perfect cleaning of the capsular bag, then the rate of PCO will be reduced. If we can see in real time where is the capsule all the time, and to know the exact relative distance between the tip of the phaco and the capsule in real time, then the rate of capsular rupture will be much lower. So where do we stand now? This is the cataract, the different steps: corneal incision, capsulorhexis, hydrodissection, nucleus extraction, lens material removal, polishing, and lens injection. So all these steps the first 3 steps can be done with femtosecond laser today. Okay, so we can cut the cornea, do the capsulorhexis, and slice the lens. So this is already kind of automated. Our team has developed within the last few years these 2 steps, and I will show you how we did and what we've done. So nucleus extraction and cortical material removal can be automated now. We have built a proof of concept for fully automated lens removal with OCT guidance. And what we are working now on is the polishing of the equator and the lens injection. So for cataract surgery, the first step is patient comes. I mean, we have not done it on human. We have done it only on pig eyes. Okay, but the first step is we do a full, complete scan of the anterior part of the eye. Okay, so it takes like a few seconds, OCT scan of the full anatomy. Then we reconstruct the anatomy, 3D reconstruction of the anatomy coming from the OCT, so the cornea, the lens, the iris, and so on. So you will tell me, okay, I mean, easy, no big deal. It's true unless you want the information in real time. Getting real-time segmentation is much more tricky. So we have developed algorithm to track the different landmark inside the eye and reconstruct in real time the anatomy of the eye. So segmentation, then when we have this segmentation done, we define, or the system will define, a safe trajectory within the lens. So we have the cornea here, the iris, the lens is here, okay, and we will define a trajectory of the tooltip within the bag, safe trajectory to remove the pieces. This is the view, 3D view from the side, this is the view from the top, where you have this initial tooltip trajectory generated inside the eye. And then we do automated lens removal. So you have the view from the top and you have the OCT. So here you have the robotic arm, okay, which is guided by the OCT. So you have a predefined trajectory inside the lens, and then depending on the position of the material or the position of the capsule, the trajectory will be adjusted on the fly. So we have let's say this is the bag, the tooltip is moving inside, OCT is scanning the whole anatomy, and if, let's say, the system discovered that there's one piece here, it can modify the trajectory on the fly to go and get the piece. So during the surgery, we don't do full scan all the time because it would be too difficult to process this information in real time. So we have the initial full scan or full 3D reconstruction of the anatomy of the anterior eye anatomy, and then during the surgery we do just a few A-scan in very particular position to assess the motion of the capsule, the motion of the cornea or whatever. And then during the surgery at certain time when needed, we do a full scan, and let's say in this case at 2 minutes after the beginning of the surgery, you can see here the posterior capsule, the iris, and there's still a lot of material inside the bag. Here after 4 minutes of tooltip navigating inside the capsular bag, there's still one remaining lenses, one piece of lens, and so the system will go and fish it, and then after a few minutes, everything's clean, the capsule is intact, everything's good, and surgery is completed. So surgeon can still override the system. So here you can see the predefined trajectory within the bag. But let's say here, this is in the instrument. We have different OCT scan performed near the tip, okay, to make sure that we know the exact distance between the tip of the phaco and the capsule. And let's say here it's an air bubble, but let's say we feel that it's a piece of lens remaining. The surgeon can click on it on the interface, and then the system will change, as you can see here, will change the trajectory and go and get that piece. So we've done surgery on 30 harvested pig eyes. Average time completion was 5 minutes, and in all cases we had a complete lens removal with no capsular rupture. So it was pretty successful. Now it's still a proof of concept. Okay, it's not a product yet. We think that we'll need another 3 years to finalize the product to make it more robust before testing it on humans. So we are planning on doing human trial for fully automated cataract in 3 years from now. For retinal surgery, same limitation as for cataract surgery. We have a lack of feedback. It's the reason why we need so much training for retinal surgery, because even if you look at the image through the microscope, there's a lot of things we guess, okay? And the more you are trained, the more you know. I mean, the less you have to guess all the time. But we have a limited visual feedback. So we think that we can, through OCT, real-time OCT acquisition and processing work, we can provide the surgeon with much more feedback. We also have a limited precision. Epiretinal membrane have, let's say, 30 to 50 micron thickness. And so knowing that the physiological tremor is 100 micron, if you're under stress or something, I mean, or the surgery is complicated, physiological tremor can be limiting. So we really think that robotic technology can help with that. There is an enormous unmet medical need in terms of feedback when we do retinal surgery. So augmented reality, you probably all know what it is. So I don't think that you watch football here. You watch more cricket or something else. But on the American football, you have, or when you look at soccer game on TV, you can see the lines which are overlaid on the image. And those lines are providing you with more information. It's kind of virtual information overlaid in real time on the image to provide you with more information. Same thing during the surgery. We can overlay through the microscope or through ideally a digital microscope like the Ingenuity or other digital microscope, any type of information, such as, let's say here, the edge of the membrane or the vessels or the neovascularization, or here, let's say a simple colored square can tell you, let's say, if you peel a membrane and you peel too much and the OCT detects some stretch of the retina, you can have the tip of the instrument becoming red or something like this, telling you like pretty straight, easily that something's going on, that you need to relax a little bit and let the membrane go. So those visual feedback can really help you. So I'm not sure if you guys use the OCT during the surgery. So there are some microscopes like the Lumira. You can get the OCT, and I have it at UCLA. However, the way the information is displayed is not really valuable, because it's very difficult to peel a membrane and look at the OCT scan at the same time. The OCT is a cross-section in a specific area, and so you need to stop doing the manipulation, scan the eye, look at the image, and then have some feedback from this. But it's not like processed information. So what we are developing is the OCT will scan all the time the retina and then process the information to tell you what you need. For instance, where is the edge of the membrane, where the membrane is separated from the retina so you can grasp it easily, and will overlay on the retina the area of separation of the epiretinal membrane, or everything you need. So we just need to process in real time this information and overlay it properly on the retina. So as I said, you can have very simple overlay like this with the tip of the instrument, changing colors.
What I just tried is connect.
Okay. So, or you can have during the peel, you know, you have the peel here, a different image overlaid. Ideally, we think that it's through digital microscope like the Ingenuity, or we are also testing some head-mounted display to find out if it's providing some better visual feedback. So other type of feedback, auditory feedback, like when you back up with a car, you have the backup camera or the backup noise. So we can provide some auditory feedback, and all this obviously is coming from the OCT scan with processed information, providing you with the feedback. And what we developed here what you see is the surgical cockpit we use for Vitreo-Retinal surgery with this robotic platform. And so from the robotic surgical cockpit, we have the visual feedback, and we have also, through the manipulators, some tactile feedback. So what we've done is we tested this system with only visual feedback, okay? Classic visual feedback with visual overlay, some augmented reality, or visual feedback with overlaid and tactile feedback. And we tested some trained surgeon, some young surgeon, and some engineers with no experience whatsoever in retinal surgery. And actually, after a few cases, the engineers were doing as well as we do, because they don't need the same training. They get all the feedback, they get all the information, so the learning curve is much faster. So in general, technology is developed to help people getting better. So I don't think that this system will really help the super good surgeon, because I mean, the guys or the women is already super good, and it's very difficult to raise a little bit more. However, there are some average surgeon, okay, in the US we have many of them, no, I'm kidding. But so there are average surgeon everywhere, and this technology can really raise the bar. It's like the vitrectomy machine from 20 years ago to today, with the high cut rate. I mean, the fluidics are much better. It makes everybody better. We really think that this system will make everybody better. So even a non-trained surgeon with all this feedback was able to accomplish very good peeling with no retinal damage. So this was done on simulators, so it was not done on human. We are planning same thing on testing this system on human in 3 years from now. So for cataract, it's fully automated. The surgeon will be just sitting at the computer, at the interface to override if needed. For retinal surgery, we are envisioning a surgery where the surgeon will be sitting at the surgical cockpit, will be provided with much more feedback, visual, auditory, and tactile feedback, and will perform the surgery with hopefully better outcomes. So in summary, robotic surgery is still in its infancy in ophthalmology, but it's coming. It's coming in all surgical field anyway. And so this technology will take over anyway for a long time. You know, technology was not ready. I really think that now technology, instead of tracking, you know, for instance, some people ask me, what will happen if the patient moves? I mean, what happens now? Our human time reaction is about 300 milliseconds. This technology, the tracking capabilities is just a few milliseconds. So system will be much faster than we are anyway to react. So now it's coming. The technology is there. It's just implementing everything, putting everything together. Now the cost will be an issue, probably, at least initially, but technology like OCT, I mean, I've seen here you have a fantastic equipment. You have everything. So the technology will get cheaper and cheaper, and will probably allow to treat more patients in the future. So robotic technology is providing enhanced capability, enhanced efficacy and safety. It's a huge sector in the medical industry. In the US, it's the market share is increased every year, and there are potential application, I think, for cataract and retina with different system, but I really think for eye surgery it will be very helpful in the future. So I would like to thank all the collaborators from the engineering department at UCLA, the computer vision, and the NIH for funding this research. Thank you very much.